So it is week 6. This is midway through. And if you think about it, it's actually more than that because week 11 is HESI and week 12, you just do remediation. And that's it, unless you have clinicals or SIMS or something due on campus. So it's pretty close to the end already. Next week is exam 2. As we were just saying, I am doing the review tomorrow at 2 p.m. And I know you have one on Saturday at 10 a.m. So try to hit one or the other. I will be posting all of the reviews in that one announcement where you do have the Cahoots are listed there, and you also have all of the professors' names. I'll just be re-editing, put it in one place. I can't stand having it put in 5 or 6 different places. I think that would drive me bonkers, especially if I had 3 classes. I wouldn't even know where to look. So I try to keep you organized along with me. So this week, you do need to turn in your congenital heart disease and cystic fibrosis case studies. And also you have open is your acute lymphoblastic leukemia. So probably after today, that ALL one will be okay for you to open and look at. Remember, there's also NCLEX questions for you. I haven't done the discussion questions yet, haven't graded them, but I'll have it done by the end of the week, you know that. So far, the discussion questions have been pretty decent. The only thing I'll tell you, if you don't get a perfect 20, I am sure it's because you're not citing in the body of a paragraph. Just that parentheses and the name of the book, comma, and the date of the publication. That's it. Put it somewhere, within the body, and that's all that's missing on most of you. I with them, so thank you. So remember next week to come in a little bit earlier if you can. I know some of you are coming from other classes to get you set up and ready to go for your exams. And we will be having a class at 4:20 to follow. And I think this week you guys get the Cahoots, and my other class gets the PowerPoint. So, we've working, back and forth with the other RN class that I'm doing. So I already have that beefed up and ready for you for next week. It's like 50 some odd questions like I normally do. So it really covers the concepts. And it's on endocrine, so it's a pretty heavy subject, but I think I cover it well. And you know how I discuss things and talk about them as I'm working the Kahoot. So I'm giving you all the information you need and then giving you those questions to quiz you on the concepts. So I think you're going to be good. I have not had problems in the past with it. So, but remember, I'm always available if you want to review those systems with me. So let's go ahead. Let's start the PowerPoint, and then we're going to go to the Cahoots. Now, Katie, are you with me today? I know Kim's camera's off. I already know why. But Katie, could you put your camera on for me? Miss McKinney, are you with me? There. Thank you so much. I appreciate it. I want you to know that Dean Brown has been popping in and out of classes for the last 2 weeks. And she takes note of whose cameras are off, who's paying attention, and who's participating, who seems like they're there or just not on a phone. So I'm just warning you, as she does it, the night classes, the day classes, just she wants to see how you all are doing, okay? And, she's checking on me too, which is okay. She can check all she wants. I have nothing to hide from because I teach and I know that. So let's go for the PowerPoint. So hematology, immunology, a lot of heavy stuff, and then we're going to go into cancer too. So it's pretty heavy things that add up in the end. So you're talking about hematology, immunology, you're talking about your blood, you're talking about your blood cells, or you're talking about your immune system, your white blood cells. So this is all about a CBC, right? With a CBC, I can see everything, what's going on. I can see if you have an infection, if it's bacterial, if it's viral, or, maybe your white count is really low for some reason, because sometimes infections will show that way. I also can see if you're anemic by a simple hemoglobin hematocrit, and I also can tell bleeding problems by low platelets. So CBC is amazing how much information it can really show. Then you put that together with a history and physical. Kids complaining of fatigue, tired. Mom says the kid's not as active, they're sleeping too much, the kid looks pale, something's wrong. So when you see those things, what's happening? Well, if you have anemia, let's think about what a red blood cell is and what does it do? Well, red blood cells carry oxygen and it carries nutrients to the cells. So if you don't have a lot of red blood cells, you're not carrying a lot of oxygen to the cells. And if you don't have oxygen, your cells don't have energy. So what your body says, go to sleep, sit down, don't move because you're tired, because you don't have oxygen, you have no energy. So that's the concept with having anemia and what that means and what you're going to see in any age person, especially children. When they have no energy, they're just going to sit there. This is why I love kids, because they don't lie. When they're sitting, something's wrong. We know that some of these things can be due to poor dietary sources. You know, some of these kids don't eat right. And we know that. We have toddlers that just want chicken nuggets and macaroni and cheese. And are they getting the iron? Probably not. Is there other ways we could give it to them? Oh, of course we could. So something that has to be evaluated. I mean, if we see a kid who's chronically ill, something's going on, let's check that CBC. Let's see if there's something else. And of course, if there's any overbleeding that doesn't stop, I'm telling you, nosebleeds are something that tells us a lot of information. I've seen quite a few times patients diagnosed with things like the immune idiopathic thrombocytopenia purpura, which is called ITP, which we're going to go over with later. So just this information can really tell us what's going on and can make a child, get them cured instead of being a chronic condition, make it just an acute. Let's get them over it and it's gone. So anemia is the most common hematologic disorder of childhood, whatever that anemia is. So again, you have a decreased number of red blood cells, you have decreased oxygen going around, you have no energy, food's not going to the cells, and the body is just tired. Now, sometimes it's because the cells aren't made, sometimes it's because of nutrition, sometimes it's because they're made and they're burst quick, you know, short life, like sickle cell, short life, they're gone. Thalassemia, you know, these cells burst constantly. And you go into other ones that they're just not producing cells the way they should. So when we have anemia, we're going to investigate, is it iron deficient or is it one of these other things I've started to talk about? And a lot of times we can tell that by the shape of those cells. I mean, thalassemia, a rectangle, sickle cell, hello, it's sickle, right? So looking at that is giving us some information. They say in children, now this is not necessarily infants, because infants can have low hemoglobin hematocrit because they don't start making their own cells till like after 6 months of age. So they've really gotten used up a lot of those cells and they've already died off. But older children, less than 10, needs to be looked at it and it needs to get those hemoglobins up. So all the ways of anemia: decreased red blood cell production, increased red blood cell loss, and then increased red blood cell destruction. So decreased red blood cell production. This has to do with nutrition. You don't have nutrition, the body said, I'm not going to produce cells, and that's it. We mostly see that with iron deficient anemia. I mean, that's common, most common of all. And then the other one we can talk about is B12. And B12 is the intrinsic factor, which helps digest foods, and we can use it in the body and feeds the body, and it helps make red blood cells, okay? Now, we have a decreased red blood cell production in something called aplastic anemia. Now, aplastic anemia, we're going to go in a little bit later, but in aplastic anemia, your white cells, red blood cells, and platelets all can be at low production. So you're at chances for bleeding, infection, and, you know, just anemia. So that's, you know, not a great diagnosis to get. We're going to go into the treatments and some more about that. ALL, acute lymphocytic leukemia, or, you know, acute myeloid leukemia, AML, ALL, both of those. you're giving chemo, you're killing cells. It's just part of, and you're dampening that bone marrow from making more cells. So those things can cause it also. Now, increased red blood cell loss. Well, any bleeding, that's number one. Nosebleeds. As I said, there's something that we will find out bleeding disorders from. If we're seeing a child who comes in complaining of epiphaxis, nosebleeds, and they're chronic, they're more than one or two. I mean, these are frequent nosebleeds. We're going to go do a CBC. And many times we're going to find some bleeding coagulopathy there. We'll be doing a CBC, and most likely they'll do a bleeding profile, that PT and APTT. And we'll be looking at those numbers along with a CBC, and we could sort of figure out what's happening here. Hemophilia, you're missing factors. You know, factor 8, factor 9, combination 8 and von Willebrand, which is another factor. You don't have a factor that helps with clotting, you're just going to bleed. So we're going to talk about that too. And then there's something called ITP. That's the immune thrombocytopenia purpura. Now, ITP, P is for platelets. Okay, that's how you remember that one, because it's really different from the other bleeding ones. IT platelets, so low platelet counts. And we're going to go how you can get that. I'm not going to go into the pathology of DIC. It is just absolutely crazy. Most nurses working takes them a while to even understand disseminated intravascular coagulation, where your body just starts bleeding out everywhere and your blood products are all over, usually due to overwhelming sepsis. So we're not going to go into that one, just that that patient is extremely ill. Sometimes it's 2 nurses to 1 patient that ill. Increased red blood cell production. Well, let's look at sickle cell anemia. Sickle cell anemia, sickle cells are produced, but those cells don't last long. So you're going to see low hemoglobin, low hematocrit in sickle cell patients. Normal ones I see are 6 and 18, 5 and 15, 7 and 21. I don't think I've ever seen a sickle cell in crisis with a hemoglobin higher than 7 on admission to the ER. So always they're going to be low. Thalassemia, thalassemia, Cooley's anemia. This is not sickle-shaped cells, it's rectangular-shaped cells, and they burst. And we're going to go into that a little bit more. And then we also have the extracorpuscle. These are more due to whether sepsis or drugs or a response to something. So let's look at anemia and what are you going to see in a child. So you get this kid coming in and mom's telling you they're tired all the time and the kid looks pale and you yourself are suspecting kid looks a little anemic. Well, what you're going to see is a little elevated heart rate. That heart is trying to beat whatever oxygen is in there around. And that heart is beating, but it's not got cells packed together. They're loose because you have all this extra fluid in there. You don't have a lot of cells to hold it. So as it goes through your valves in the heart, you're going to hear murmurs. You're going to hear swooshing going on. So one of the first things I would do is listen to the heart. What's the heart rate? And do I hear a murmur going on there? That's because you can literally hear it. Now, because your heart's beating quicker, trying to get whatever oxygen's around in the body, your heart's going to fail if you let it keep going on and on. So heart failure can happen. You might see some cyanosis, some, maybe circummoral cyanosis. You're going to see something. And if it's prolonged, this child's not going to be as big as they should be because they're not getting nutrition or oxygen. Your body don't grow. It's part of it. So diagnosing, as I said, history, physical, CBC, basic right there. Now, we could go ahead and say, okay, you're anemic and let's just give some blood. And one thing I can't stand in medical science today is you have hypertension, they give you a blood pressure pill. What caused that hypertension? Can we correct it? We have nausea and vomiting. Give me a pill. What caused it? Same thing with anemia. What is it? Do we think it's iron? Do we think it's what? So don't just think a transfusion is going to cure the anemia. It's going to happen again and again and again until we find that cause. So if it's nutrition, fine. I mean, yes, if it's anemic, we're going to give that blood. We're going to get that heart, slowing down and not working so hard and beef up those red blood cells. But we need to find out the why, what happened there. So we'll start that IV. We're going to give some fluid. Hopefully we'll slow that heart rate down a little bit. And then this is controversial. Does oxygen work if there's no red blood cells to carry it around? That's debatable. Today, in many cases, you'll see me go like this. It's debatable. If you don't have red blood cells, what's carrying the oxygen? But, it's sort of, if there's a chance of a little bit more oxygen, well, why not? The best thing is actually bed rest, okay? Decrease the expenditure of energy. Now, as we're looking and we're doing our assessment, the age of the child and the racial or ethnic background is going to be very important. Well, we know African-American sickle cell anemia. That's number one. We also know from the Mediterranean is also thalassemia. So if we're suspecting one or the other, guess what? We've got two clues to tell us. Is it sickle cell or is it a thalassemia? And let's rule out an active bleed. That's the number one way to rule it out. Are we bleeding? Do we have, kids do get ulcers. I mean, they're little stressed people. They worry about everything. There are some children like that, and they can have ulcers, or they could have an IBS, something going on in their intestines, and they could bleed. So stool for alcohol blood, very important, rule it out. Now, of course, these kids, they're going to be getting some sort of blood tests, and probably more than one, because now they're a history of anemia. We need to follow up and make sure they're doing okay. So always go on their level, get them ready on their developmental level so that they're not going to be afraid of us. As we're doing these things, these kids don't need to be screaming and yelling. Try to use all those numbing creams, talking with them, using Child Life, whatever. And this can also help with complications. As we're managing anemia, child at home, they don't need to be out running around outside if they're anemic until we get blood counts up there too. So everything we do with a kid with anemia, we need to try to decrease the amount of oxygen needs. So, more at rest. So iron deficient anemia, it's just not enough iron in the diet. Now, infants, if they're born, they have, either breast milk or iron fortified formulas. 20 years ago, they didn't give iron, believe it or not. And then they realized, why don't we? Because that iron can help with the red blood cells and making your child healthy and stronger. So now we do. Also, the cereals that we introduce at 6 months also have iron. Premature infants, there's all sorts of special formulas on them. You can get up to 30 calories per ounce, and your normal formula is 20 calories per ounce. Your normal Enfamil is 20 calories per ounce. But for infants, we do have some that can go to 30 with extra iron and all of these things in there. Now, adolescents, we don't talk about them in iron deficient anemia, but don't they have that big growth spurt that goes on pre-adolescent? 20 to 25% of their body is grown during this 2 to 3 year period. Well, they need extra iron and extra nutrients. And what do the adolescents do? Well, I'm too fat, I'm on a diet, or they're too busy. They grab a power bar and a bottle of water, run out the house, and they never eat anything else. They're not getting nutrition. And that can cause that iron deficient anemia. Another thing, and we've sort of eliminated it in many places, not completely, but what we call milk babies. Regular whole milk does not have iron in it. It doesn't have what it needs. So those are called milk babies, okay? So how do we take care of iron deficient anemia? Well, we give this kid more iron in their diet. Now, if they're not eating it in their diet and we can't get it in them, then we can give them iron. Remember, if we give liquid iron, if the kid's old enough to sip through a straw, we need to put it in a straw because we don't want to stain their teeth. because they will get brown. They will. So as we were taught in pharmacology, because remember, I used to teach pharmacology, that's what you teach, a straw. So sickle cell. Sickle cell, we know, is sickle-shaped cells, and the big thing is the African Americans are the carriers. You have two carriers, mom and dad. Child has a 25% chance of having that disease. Now, what do you see in sickle cell anemia? Well, let me make it just very easy for you. You have these sickle-shaped cells. They're going through vessels and they bifurcate. And all of a sudden that sickle cell doesn't enter it right and it gets stuck. Now, that's a dam. Blood can't get down. So cells come up and it packs up, and it swells and causes pain there. Now, why was that cell not big enough to accept that cell? This is what happens in sickle cell anemia. Whether the kid got cold, whether the kid got dehydrated, we need to dilate those vessels now to let that sickle cell go down and the other ones will follow. Now, it's painful. So you think priority care is to give pain medicine. No, you're treating the symptom. What's the cause? Very small vessels. So number one, bolus of IV fluid, perk up those veins, put a hot pack on it, dilate those veins, and those sickle cells will go through and that will be the end of it. So if we don't do that, you're going to see the area distal, let's say it's the elbow, your hand, your fingers, they're going to start getting numb and discolored because no blood's going down there. So the quicker we can get blood returning where it goes, your pain's going to go away and the child will return to where they need to be, at home and being kids. So, okay, gotcha. Sickle cell crisis, what happens? Well, as I said, vessels get small. Well, it happens in many different ways. I mean, just think about a little fever and sensible water loss, right? Causes dehydration, and we don't even think of it. And kids don't like to eat or drink when they are fever or sick. They just want to sit in the corner and do nothing. That's why I've always emphasized, get that fever down, let that kid drink at least, because that's what we need to do for fevers. Any trauma, ecchymotic areas, decreasing the narrowness of those vessels, that's going to cause sickle cells. Of course, infection goes along with fever. Stress. I've had many nursing students have almost a sickle cell crisis every single semester during nursing school. You're not stressed at all, are you? Hello? Yes. So this does cause it, and it's very evident when you see these certain students who do have sickle cell, not the trait, but the disease, and they end up being hospitalized because of it. Emotional distress, physical distress. So also that dehydration is huge because it causes hypoxemia, and that's all the pain. So what do we do? What do we do? You're having a crisis. Remember, it could be in eyes, it can be in heads, it can be chest, it can be elbows, arms, anywhere. I mean, many times you'll see it in an elbow, you'll see it in a knee. A lot of times, actually, it's in the chest that they're feeling these sort of things. Number one, they need to lay down, stop moving, because now they don't have blood flowing around. And remember that extremity or whatever is not getting blood. So you need to slow down the metabolism, try to slow down that heart rate. Priority, hydration. Number one, hydration. Put heat on it. And we definitely will be looking at electrolytes with this because you have a lot of electrolyte imbalances, especially with potassium. And what caused the sickle cell crisis? Was it an infection? Many times it is, believe it or not. 100.5, that patient must call a physician to get prophylactic antibiotics because these are immunosuppressed children or adults. They're just immunosuppressed. So they need to get these antibiotics. I mean, yes, they are placed on prophylactic antibiotics as young children. Now, why do you think young children get prophylactic? One antibiotic a day, it's penicillin. Think about their immune systems. 2-month-old, do they have an immune system? Not really. And up to 5 years, we are making sure we're doing everything to prevent infections in these young children so they don't go into crisis, okay? Now, with all these things, there was no mention of pain, right? Well, as I start an IV, I'm going to have my pain medicine in my hand, okay? But priority is your hydration, because it's always like, well, aren't you going to medicate for pain? Well, absolutely. These kids usually are crying. So that's the first thing I'm going to run for with my IVs. Definitely, we're going to be monitoring the reticulocyte counts. We want to see how those cells are being formed. And because I'm telling you, these blood cells die quickly, their hemoglobin hematocrits are low, we need to get oxygen back to that child. Blood transfusions are given. And working in an emergency room that I did the last 10 years of my career, we start them in the emergency room. That's how much they need them quickly. You know, we don't wait till they go upstairs. No, they're started in the ER. Blood transfusions started in the ER are emergencies. We just don't do them routinely. There is no cure. We know they're immunosuppressed, and we know that, you know, there's going to be all these infections, et cetera. And that's what usually will kill a child if they don't get in for medical treatment as soon as they can. I mean, you'll hear stories of single parents and they're not off till tomorrow, so kids have to wait. And that's just life. That's what they have to work with. But that's usually what will be their demise. So we encourage them. Yeah, I know you're not supposed to miss work. I know you need money, but you know your kid is that important. These children do live at least into their 50s or more if they take care of themselves, keep themselves hydrated, keep themselves warm, you know, give themselves rest if they're out being normal kids, right? That's what they want them to be normal. But they should be making sure that they're drinking maybe an electrolyte solution, keeping hydrated, resting, not just go for an entire game. So seek early intervention. I think you've heard that already. Give penicillin, you know, that's that prophylactic that we give. And then if they come in, they're having a fever and they get into us, we're going to be starting IV antibiotics for sure. Now, sickle cell is going to occur in the head and in the chest, and sometimes they'll mimic a stroke or a blood clot, a pulmonary embolus. So make sure that if we're having a headache on a sickle cell child, check your neurosigns. Absolutely check neurosigns. Don't think it's just a little headache, because it could be a sickle crisis in the head, okay? And always we want to, of course, treat that kid normally, but we want to prevent sickling. And that's teaching them what they have to do to prevent them from getting all of this pain. Now, thalassemia, again, it's the Mediterranean Sea descendants of. These are cells, I call these the rectangular shaped cells. And there's a very, very short life of these. They're produced. There's no problem with that. But they're produced and they burst. Now, what's inside a red blood cell? Oxygen and iron, right? So these patients get iron like crazy bursting into their blood system, and it could become toxic. Can you imagine that? That's the big deal with this one. Now, there are 4 types of thalassemia, but when we talk about thalassemia, you're just going to hear Cooley's anemia, which is the most severe of all of the types of thalassemia. This person, child, adult, doesn't matter, because you can become an adult with this, they're going to need regular blood transfusions, okay, to live, because their body's not making cells that work. And many a times what you will see is they'll take the spleen out to try to stop cells from being produced. So thalassemia, we don't necessarily see right as a newborn. We see it a little bit when all of a sudden the kid's not growing the way it should, because they're not getting oxygen and nutrients because these cells are bursting, and maybe they have little toxic looks or seizures because of the iron that's being spewed into that blood system. That's sometimes the way that they figure it out. You can see the red blood cells don't change till 6 weeks old. So what do you see? You know, what do we do every visit for a child? Height and weight. Why do we do that? We're trying to find things quick so that they don't go onward and we missed it. That height and weight shows so many things on children. nutritional, they're not getting nutrition, or there could be growth hormone stuff, or it could be something like thalassemia where they're not, and they're anemic and they're not getting what they need. So height and weight is so important. So what do we do for these kids? Blood transfusions regularly and some sort of iron chelation something treatment. Now, there is something called defoxamine or desferal. This takes the iron out of the blood and it's excreted through the kidneys. Because remember, iron can become extremely toxic, okay? There's also something called apheresis. It's a machine that looks like dialysis, but it only takes out whatever blood component you want, and it can just take out iron, okay? And actually nurses run these right at the bedside at the ICU, and they can take out whatever, take out just platelets or just take out albumin or whatever you need. It's a really neat thing that they can do it, especially if they are at a toxic level. You can't wait for a PO medicine to work. It's not going to be quick enough. So how do we manage this? Chelation medicines and transfusions. Now, remember, this kid is chronically in and out of the hospital. So their blood is going from really good, and then it's like, I'm very tired, and I'm really nice, and I'm really tired. These kids are all over the place. They need good support. They need what they call good coping skills to deal with all this. Not only the child, but the family. And you're getting multiple blood transfusions. So many of these children end up with these weird antigens in their blood and become a very difficult thing to get blood. So look for also those complications. You live into adulthood, as I said, maybe you're going to have a spleen come out. Sometimes these kids are immunosuppressed too. So sometimes there is that post-splenectomy sepsis. And remember, with anemia, what happens is you get heartbeat's good, and all of a sudden your blood's down, then your heart's like beep, 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 beep. So heart failure, heart disease can occur. Same thing like in any other anemia. We want to slow that heart down and try to keep it working as little as it possibly can. Bone marrow transplant, does it work? Well, they say possible. It's not been proven in every case. Now, aplastic anemia, there's two types. But usually when we think of it, we think of the one that is the pancocytopenia. All types of blood, red blood cells, white blood cells, and platelets. Leukopenia is decreased white blood cells. Thrombocytopenia, P platelets, decreased platelets. So just know those terms, okay? Those terms you're going to hear again. Leukopenia and thrombocytopenia. Now, there is one that you just don't have red blood cells, but everything else is okay. But usually it's the first one in aplastic anemia that you will see. So how do we treat it? We treat it like cancer, honestly. We give immunosuppressive, we give bone marrow transplants to try to make those bone marrow start producing what it needs to. We try to eradicate what's there and give a bone marrow and try to make it produce the way. That's the only way I can describe it. And that's just like acute lymphocytic or myelolytic leukemias. Let's kill what's in there and let's replace it with something, and hopefully it's going to produce the proper cells. Okay, decreases in hemostasis, which means bleeding. Bleeding can be anywhere, right? But we think of hemophilia. Hemophiliacs, it is an X-linked recessive trait. So mommy passes this on, okay? It is usually hemophilia A, factor 8. I've always heard factor 8 when I think of hemophilia, but there's factor 9, and there's also the one von Willebrand. I guess he was a research scientist who found another factor, and he put his name on it, von Willebrand. I mean, parents will come in and say, yeah, my child is von Willebrand's disease. And when I first heard that, I'm like, what does that mean? So of course, I went and looked it up because I'm a nerd, and I always want to know everything about everything. But it also has to do with factor 8. So how do you diagnose hemophilia? Well, sometimes you don't even know till later on in life. It doesn't mean that they're not going to be chosen at birth. Sometimes it could be later on, or If we know the parent, the mother has it or has the trait, we might look for it. But usually what you're going to start to see is there's bleeding. Could be bleeding and epiphaxis, nosebleeds, the gums are bleeding, a cut is bleeding, it's not healing. It could be the hemarthrosis, which means bleeding into the joint sacs. Now, blood in a joint sac is toxic and it can cause a lot of damage. So these kids can become cripples if we don't stop that blood quickly, okay? So we'll go on and I'll explain more. And then of course, bruising. Give an IM injection to these kids and they're going to bleed underneath and bleed and bleed and bleed and bleed and bleed because they have no clotting factors. Now, what do you see with hemophilia? Well, if you had the time, which takes about a week to get a factor back, you'll see factor 8, factor 9, factor von Willebrand. You'll see them depleted. But usually you don't have that week to wait. And usually they'll make the determination on the PTT time, APTT. That's used for heparin, right? Heparin is monitored, the coagulopathy of it, by the APTT, the prolonged partial thromboplastin time. Now, it'll be elevated. So normals are what? 20 to 40, around 40, they're going to be 200 or more. So you're going to say, wow, why is this kid like that? I mean, we're not on aspirin, we're not on anticoagulants, we're not on heparin, all right? I mean, anticoagulants would have a prothrombin time. It wouldn't be that. So it makes you think. So platelet counts are normal in these children. So all you're going to see is that PTT that's going to be elevated on that. And then when you get in those factors, you'll see the other. They do draw these parathiohormone and the fibrinogen levels. These are something we actually do when these kids are on, these bleeding on these machines for cardiac output, like a ECMO or open heart things. We'll always be pulling them, looking for their bleeding coagulopathies, but they're not a normal test that we do regularly. But platelets are normal. So PTT up, platelets normal. Now, the kid fell at home and his blood in his knee and it's getting bigger. And what do? Well, I had a case of a 9-year-old boy who came in with his father, and they came in with their little factor 8 in a bag with all the equipment, but they couldn't get a hold of their hematologist. So they came into the ER and asked our physician, I don't know what to do. Apparently he had a factor 8 maybe a week or two earlier. They didn't know if it was too early to give it again, but they wanted to do the proper thing. So our physician said, yeah, look at the knee. It was, a lot of ecchymotic area, painful. Yes, let's give it to him. Well, the father said, do you mind if I give it to my son? And I said to the son, you want your dad to do it? And he goes, yes, please. And I went, okay. Now I had an orientee with me, brand new nurse into nursing, orienting, and the father wanted to do it. And I said, do you mind if we watch? And he goes, no. I watched him do probably one of the best IV sticks, best, asepsis I've seen. He washed his hands, he put out his equipment, he used alcohol and wipes, he mixed up the factor because it's a powder. You have to mix it up, put it in a syringe with tubing. The kid picked out which vein he wanted to use in his arm, and he held the butterfly needle there while the father pushed in this factor. Pulled it out, put a Band-Aid on, that was the end of it. And I just went, Dad, you got an A++ from me. It was amazing that that father and that son, you don't always see, number one, a dad doing it. And number two, that kid just knew he had to do it, and he was just a part of the team, and it was no big deal. So the end of the moral of the story, if a parent wants to do it, why not? They do it at home. Why not do it now? Now, there are some milder hemophilias, not many, but there are some, and they can use desmopressin, which is DDAVP. Now, DDAVP is used for diabetes insipidus. We're going to study that next week. It's something that we give to stop the kidneys from urinating, but this is also used in hemophilia. So that's one of those, which one is it used for? And then there's aminocaproic acid, and we sometimes use that also. So at home, what are you going to teach a kid? Hemophiliacs. Number one, You got a toddler at home who's diagnosed with hemophilia. You better take every sharp corner in that house and pat it with something. Because what do toddlers do? They run in it, they're going to cut themselves, and they're going to be chronically on factor because they're always bleeding, right? That's a good safety thing that you'll see. That's something questions you'll see on HESIs and NCLEXs. I'm warning you there. Now, kid fell at home. We're going to do just like what they would do if they had a sprained ankle or a sprained whatever. Number one, you are going to stop, rest, ice it, compress it, and elevate it. I mean, I used to kill my ankle constantly playing volleyball. I don't know why in high school. I'd go up, spike the thing, do really good, come down on my ankle, and I could hear it go. First thing I do is stick my ankle way up in the air because I could feel it just filling up with fluid. So can you imagine a hemophiliac that's at the blood's just filling up there? So you do those things and you're going to protect those joints, which is what we want to do. Now, hemophiliacs can live normally, but they're not going to be in football. They're not going to be in sports that can create a lot of bleeding. They might be in swimming or bowling or maybe tennis, other stuff they can do. Try to get them normal. All kids. You don't want to make them feel like they're different. Kids don't want to be different. They want to be like the other kids, okay? Now, again, controlling those symptoms does what? It limits that joint damage because of that hemoarthrosis. We don't want those kids not to be crippled by the time that they're adults. It's just not what we want. And there is a gene therapy. It's being introduced. It's sort of being used now, but it's still not completely out yet. Now, I mentioned this idiopathic thrombocytopenia purpura, P, platelets, right? Remember, ITP is called immune thrombocytopenia. There's all different names, but the big name, the little initials, ITP. ITP is excessive destruction of platelets, which means your platelet levels could be 10,000. Now, you need platelets in order to stop bleeding. You also know that platelets are, when you don't have enough, you're going to see that's what we call a little purpural type of rash. Now, you see that little rash on that arm? I've had several kids come in to the ER. Mother says they don't play outside. All they do is play video games and watch TV. And why are they bruising? And what's this rash from? I don't know where he got it. We go, let's do a CBC, right? And of course, we'll do bleeding coagulopathies, PT, PTT, just to be sure. But we're probably pretty sure it's a platelet. And part of the history, they've had an upper respiratory infection within the last 2 months. And that could be what, sets us off. So no platelets because of this respiratory infection. And there's two things that can happen with thrombocytopenia purpura. Now, there's chronic and there's acute. If it lasts more than 12 months, we consider that a chronic condition, which will need chronic treatment. How do we treat this acute stage? Because that's when we first see it. They've had an upper respiratory, they've got low platelets, and we see this purpura rash all over. Maybe it came in with a nosebleed, because this is the one that will come in with a nosebleed most of the time, nosebleeds. We're going to give them IVIG, intravenous immune globulins, and anti-D antibody. Now, go back down to the care management. Sometimes we give corticosteroids, okay? Now, you've just got a kid, just admitted, he's got ITP, and you need to take care of him. Well, this condition has nothing to do with fluid and IVs, none of that. It's not in the vessels. It's little purpural rash in the body. So you don't need to start an IV. You need to start an IV only for the medicines, okay? Not to bolus. Bolus is nothing for these people. Now, everything we do is bleeding precautions. No IM, sub-Q, injections. If we need to start an IV, make sure you got your specialist there because you don't want to keep poking, because these kids will bleed. Their platelets are low. Any kid with low platelets, you're bleeding precautions for whatever reason. You're going to monitor for bleeding, that nosebleed, the gum bleed, urine, stool, their body, looking for areas. Again, protect that environment you have these kids in, because as I said, younger kids, they will bounce into things and cause bruising, etc. And because they're in the hospital, we're going to be monitoring their blood counts. We're going to be looking at their CBC, looking at their platelets. So the kid came in with an epiphaxis. It's many times this is what diagnoses one of those bleeding coagulopathy problems, whether it's leukemia or ITP or von Willebrand's or an hemophilia. So how do we take care of this kid? Well, the first thing we need to do is get that kid calm, because an elevated heart rate and adrenaline, and they're scared and they're nervous. Guess what? Heart's beating more, they're bleeding more, and it's going to be harder to stop. So just put them in your lap, calm down, pinch their nose with a finger and your thumb, lean them forward so that they're not swallowing the blood. They can spit it out of their mouths, okay? And if it's, at home this has happened and you've taught them how to do it, if after 10 minutes they still have bleeding, they need to seek medical care, whether go to their doctor, go to urgent care, whether go to ER, because something's wrong. After 10 minutes, any normal nosebleed should stop. Okay, an immune issue, HIV/AIDS, right? It's a virus. So one of the things that we think about when we think about HIV/AIDS is those newborn infants born of the HIV mother. Now, many times you'll have a parent that's aware and they're proactive in the care, and to try to help their child, they put them on a highly active antiretroviral therapy, or HAART. And they do that about 22 weeks gestation, and then after birth, we'll stick them on more antivirals. Why do we do that? Well, what do the antivirals do? It boosts their immune system. We're trying to get rid of that virus. It's not an antibiotic. It is an antiviral, and it helps the immune system get better. So the thing about newborns is, they're born HIV, we're giving their antivirals. I have seen many children go from HIV positive 1 year of age, they're negative, because they got treatment as soon as they possibly could. I've seen triplets, 3 babies, 3 girls. One had AIDS, one had HIV, and one had nothing from one pregnancy. So I've seen all different combinations. So just because a mother has HIV doesn't mean every baby is going to have HIV. That's something I like to share that I've seen firsthand, because you think it's just really a death sentence for them. It's not at all. Now, they do get some common opportunistic infections. The respiratory one is pneumocystic cardiac pneumonia, PCP pneumonia. That's a common one that they get. And another one they can get is your yeast, your candidiasis, that they also can get. So remember, when we're talking HIV/AIDS, we're going to be teaching, this is something that, sex and safe sex is something with adolescents that hopefully we could talk to them about. So with all of these things, and we're dealing with all of this hematological stuff and immune disorders, you see we're giving a lot of blood transfusions, or maybe platelet transfusions in that ITP person, right? So blood transfusions, be aware that reactions can occur. Make sure that you give within the guideline of the hospital. Many of them say take vital signs, 15 minutes later, take another set. And in that 15 minutes after blood started, I've seen reactions in 15 minutes. And then 1 hour thereafter. Sometimes it's a spiked temperature, sometimes it's rash, sometimes it's respiratory distress. I've seen all 3 that it can happen. First thing you do when you see a reaction, turn it off, get it out of there. Go right down to the hub, get that tubing out of there, flush the tubing, and that's it. I've mentioned apheresis. Apheresis is removal of blood or components, and we just take what we want, and it cleans the blood. It could be used in that thalassemia, as I said. Or maybe we're going to take out platelets from me to give to my daughter, whatever it is. Now, a lot of times because you're looking at bone marrow and you're looking at blood production, many children do get bone marrow aspirations. We need to look at the cells. What do they look like? With children, don't tell them it's not going to hurt. Don't lie. Kids don't want to hear that. Tell them it's going to hurt a little, but I'm doing everything I can so it won't. And you're going to feel me touching you. And if it's hurt, you let me know and we'll slow down. That's all they want to hear. And even little 3-year-olds understand this more than you could understand. When you sit on their level and get down on them and just let them talk, ask questions, you can get these procedures done so much easier. So both parents have sickle cell trait. What's the chance that their children will have sickle cell? What do you think?
Hey.
Yes, 25% for sure. All right, neoplastic disorders. You know, over half of all cancers are blood and blood forming. These are leukemias and lymphomas. So leukemia. Well, what is leukemia? Well, I like the next slide that says, leukemia is an unrestricted proliferation of immature white blood cells in the blood forming tissue, which means your body is producing white blood cells, but they're immature. They don't work. They're infants. They do nothing. So you don't have a white count. You will see this. It's the most common, actually, of all childhood cancers. Usually the ALL, which is easier to cure than the AML, okay? And more frequent in boys. And look at the ages 2 to 5. It's really devastating when a parent is told your child has leukemia. Many times it's done in the ER, and you as a nurse just have to sit there and support them. Survivability is great today, as long as they follow the treatment. So how do we diagnose leukemia? Well, I had an next-door neighbor. She was, I think, an older one. She was like 13 or 14 years old. And she went to the ER. She was really tired. She had a fever. She wasn't herself. She had bruising and her knee was hurting so bad. And her parents brought her in. They did a CBC and they found her white blood cell count 0.1. I was devastated with mom because the kids were always at my house. I mean, they were Korean, so they used to come over and do Easter and Christmas and make all the things, Halloween. We used to do all these things with me. I was introducing them into American culture, and they were introducing me into theirs. Great, great family. When I moved, the parents came over and cried. They didn't want me to leave when I bought a house down south. But this little girl went through all of these treatments. Today, just to let you know, she has a PhD in psychology from the University of Miami. So it did not affect her brain. She was a smart girl. Anyway, what did they do to her when they saw her? Because of the history, these are typical signs. Fever, general being tired, malaise, lethargy, bruising and pains, like usually bone pain. So they drew a CBC and they looked at the cells, and they're going to see.
Don't they put them on neutropenic precautions?
Absolutely. Absolutely. These kids, number one, is always hand washing. Neutropenia, number one, washing hands. Neutropenic means you're going to try to prevent them from getting infections. Absolutely. You're going to wear masks in their rooms until we can get those white cells up. These kids are all placed usually on an oncology floor, where the nurses and staff really understand how to take care of them. Yes, absolutely. So leukocytes, they're immature and they're hardly ever there. And a lot of times their hemoglobin hematocrits are also really low. That's all this bleeding that's going on. They're going to do a lumbar puncture. They want to look at the central nervous system and see if it's involved there. And then, of course, they're going to do that bone marrow biopsy. They want to see how cells are being produced. And they want to look at them underneath slides. And again, let the kid know it's going to hurt. Now, you've been diagnosed, and now they're going to be starting the treatment for leukemia. Many of these kids, I've never seen one without it. They put a port in, which is underneath the skin. So when they go home, they don't have to worry about things flopping around or pulling out, okay? And when they come in for, let's say they come in because they got a fever at home, very common thing to occur, they put little numbing on the area where the port is with a Band-Aid and come in, and they're ready for us to put a needle in and access the port. All right, so they come in and they're going to start the first 4 to 6 weeks of therapy. And they could be 2, 3 different sorts of chemo. It depends on the doctor, depends on, the cells that they're seeing, et cetera, and the blood count. What is that white count when they come in? Now, in that 4 to 6 weeks, the goal is remission, which means they're going to kill all the cells. All those terrible white blood cells that are cancerous, they're going to be gone. But there's always a little bit left. There's always little sneaky ones, right? Now, we're going to go intrathecal. We're going to get that central nervous system, make sure that's okay, clean. And then we're going to go on this consolidation. And that's to get the sneaky cells and get rid of them. Once we're sure all cells are gone, they're going to be on maintenance. And depending on the kid, could be a year of maintenance or whatever the doctor wants it to be. But induction, goal is remission. So in 4 to 6 weeks, that cancer should be almost completely gone out of that body. Now, one of the ways we treat leukemia is a hemopoetic stem cell transplantation. Now, the one thing about these transplants, you don't have to have A positive. It doesn't have to be your family. It doesn't, it's not like blood. It's completely different. We describe them as 2 different types. Now, autogenic or autologous, as I call it, is automatically my blood. It's automatically the best if I have it. That's usually umbilical cord blood. Now, allogenic, everybody else, right? Everybody else, automatically mine. These are 2 names you need to remember, okay? So if I have something already saved, they wipe out all of the cells, all the immune system, and then they insert this and they wait for the body to start making their cells again. And that's how they cure leukemia, okay? Kill everything that's in there. And then, of course, you are really neutropenic, Carrie. This is when you go to the bone marrow unit where you're in reverse flow air rooms and you don't walk in or out of that without booties and coats and hats and masks and everything, because we don't want to bring anything into that child. So until we start seeing the body start making cells. So autologous is my stuff. Allogenic means everybody else. So as I said, that kid came in, had a fever, was having some hemorrhaging, bruising, and was in pain. So make sure these kids understand what's going on. If I'm going to insert a port in the kid's neck, just say, you're going to feel me touching and it's going to be done in a second. I just have to tape it up and then you'll be okay. If they want to see the stuff, let them see what you're doing. It's a very simple procedure, but you need the kids' cooperation. Always relieve that pain. It does hurt, and make sure we give it, as ordered. Again, don't let it get too bad. Infection, most of the time you see leukemia. There's no white count. There's no immune system. So giving those antibiotics, a lot of times you need to give blood because of these, bruising or hemorrhaging somewhere, because now you're anemic because of all the above. Remember, with leukemia, you're killing good cells along with bad cells. So good white cells, good red cells, they're all going to be killed too. So it's going to be looking at it. Now, if any of you want to be a traveling nurse, go somewhere and get your chemo certification in pediatrics. You can go find a place to be hired with sign-on bonuses in $20,000 to sign on for a 2-year commitment. This is one of those places you want to make money, you want to travel, chemo, and children. There's not many nurses who want to do it.
How much does it cost to get that certification?
You go to a hospital and you go into oncology and with children, and through their hospital, they will give you programs to get you certified, to get you trained to take care of these children. And through that, they'll do their certification. And then, of course, there is the oncology nurse by, you know, those certification things like I'm CPENs, there's CPN, there's all different, CCRN, you have CON, Certified Oncology Nurse, CPON, Certified Pediatric Oncology Nurse. That one, sometimes many hospitals will pay it for you. So find a place. It is, you know, a great thing to do. And I tell you that, you know, not every patient is going to live, whether they're a child or adult. So just remember, it's what did you do while they were alive? How did you help them? How did you touch them? How did you make the family feel, them feel? I mean, I have no regrets for any child who's ever died with, that was my kid, because they were my kids when they were in the hospital. And I cried with parents, and there's nothing wrong with it because I'm a human. So I know that's the hardest part of that chemo. Anyway, what's the diagnosis? How do you know the prognosis for these children? Well, what was their white count when they came in? Was it 0.1 like this girl, my neighbor, or is it 0.01? That's more severe, okay? How old were they and what cell? Was it the ALL or AML? AML is harder, as I said. Male, female makes a difference. And then what's your blood type? Because remember, we're giving a lot of blood products. Do you have that availability when you need it to give it when you need it? Or do you have to find that blood because it's a rare blood type? So we're going to go into some more cancers. Now we're going to talk more about some, you know, more of tumor type things. We give radiation, chemo, surgery, and let's go into some of these things. Now, in cancer, what are we going to see? Similar to your leukemia, pain, fever, ecchymosis, petechiae, bleeding, lethargy, and then it goes into if it's going on, that weight loss, etc. And sometimes you see these big lumps of tumor. You can see them in the belly or in the under the arms and the neck, could be somewhere. Now, as we're treating these children, one of the things I want to tell you about is a neutrophil count. Now, a neutrophil count is one of the white cells that help fight infection. Many children, not even leukemia, but with other diagnoses, due to whatever reason, will have low white blood cells, which is low neutrophil counts. Now, neutrophil count should be well over 1,000, close to 2,000. So when you are lower than 500, you are at extreme risk for infection. So one of these things that they like to test you on with neutrophil counts is you're given a group of patients to take care of. Which one are you going to go? What's your priority? Well, a kid with a low white neutrophil count is going to be number one. That's going to be the one who's the most dangerous, the one that could go septic shock right away. There is no immune system on that child, nothing to fight infection, okay? So that's what that is. Now, fighting septic shock, of course, you're always going to be monitoring vital signs and temperatures and giving antibiotics and doing all sorts of culture sensitivities. And the biggest thing is to try to prevent infections. I mean, number one priority is washing your hands, walking into every single patient's room. That's why they have alcohol things in front of every room today. It's amazing how many all of a sudden went up. Because when I first started nursing, they weren't everywhere. You had to find a sink with soap to use. Of course, hemorrhage, as I said, all top parts of your blood can be affected. So giving platelets, giving transfusions. One of the things, if you have a child who's at risk for bleeding, make sure, I mean, we want a kid to be a kid, but we don't want a kid to be in a place where it's dangerous. Like out riding a bike, a skateboard, or playing football, it's not a good deal because these children will end up with, you know, damage, bleeding, and it could be extremely dangerous. So anemia, when we're having it, whichever, because of the reason, whether leukemia or iron deficient anemia or anything, remember there's no oxygen. So limit their exercise, you know, or the expenditure of energy because they have none. You've always heard with chemo, there's always going to be nausea and vomiting with the chemotherapy infusion. Years ago, we didn't give any sort of antiemetic until after they vomited, believe it or not. This is a change in practice. Give it before they vomit. Gee, isn't that something that we should have done? Well, we didn't know until, of course, we researched it, because that's what nurses do. They're also using these synthetic cannabinoids very, very successfully. Not every state believes in it. And the one thing about using it is make sure the physician knows that it could be a part of the practice. So he knows that that's being given with the other medications they need to give. That was a documentary I saw that the medical doctors weren't told, and they need to know everything that's going on. Whether they agree with it or not, they have to know it in order to be able to treat the patient the most effective, right? Again, they get these blisters in their mouth and they don't want to eat. They're nausea, they're vomiting. So how are we going to look at nutrition? Well, of course, you're always going to monitor what they take in. That's always a given with this condition. Height and weight, right? We do height and weight every morning on these children. We want to see what's going on, if they have the ability to get out of bed. Sometimes it might be once a week if they're that debilitated, depending. And we'll be monitoring all sorts of lab works on them. And their diet, high in everything, high protein, high calorie, high fat. Whatever little bite they get, we want the most nutrition in every little bite, because they only might take 2 or 3 bites in. We want it to be the best they can get. If their mouth, remember, mucosal goes from mouth to anus, anywhere in between that they could be hurting. So making sure that we have bland foods if we can. Sometimes you would think parents, they want to put lidocaine in the mouth for the numbing, so all this stuff. Well, if they swallow that, then now they don't have a gag reflex, and now they can have aspiration. So we don't use it in these children. And if, of course, there's anything with hemorrhoids or that sort of mucal, of course, we'll put them in a sitz bath if we need to. And then neurological problems. One of the things with any cancer, it causes pain, right? Pain medicine, what happens? Constipation. What happens if a child or an adult is constipated? They're going to push down, right, to have their stools. It could cause strokes. So making sure that either the diet we include enough fiber, or they're on a medicine to help loosen their stool so they don't have to bear down. One of the things we don't think about, but I'm telling you, it can happen, and I've seen it. So hemorrhagic cystitis, sometimes you'll even see blood in the urine. So make sure that they're getting plenty of fluids, whether it's IV or PO. And of course, you always think of little kids and adults that lose their hair under chemo. I've seen fathers and brothers and all sorts of people shave their heads. I mean, I used to have bows and ribbons that I used to bring in for these kids. I used to go to wherever, Walgreens or Walmart, and buy those little spools of all different colored ribbons. Come in and I'd say to the girl, okay, what color are we going to wear today? And I would wear a headband with whatever colors or multicolors as the kid did. And I was her special nurse for the day. And she had a pretty bow on and she felt beautiful because I said, oh, you're so beautiful. Because it's what you feel, right? It's that mental status. And mental status helps kids feel better quicker. Now, many times these kids are on steroids. Remember Cushing syndrome? I had it a couple of years ago with rheumatoid arthritis. They gave me too much too long, and I was this big Pillsbury Dough girl. I mean, it was quite impressive the amount of weight that I gained with it. Small kids, especially if you're getting into those young adults, they're really self-conscious. So make sure they have looser fitting, either their gowns or jammies or something, because they don't want to be feeling like they're big and pudgy. I mean, no kid does. Always get them prepared for procedures. Many times they're going to be in a conscious sedation, so they'll be half awake, half asleep. Again, we're using topical anesthetics, whether it's EMLA cream for putting the port in. And then as we're doing like bone biopsies, bone marrow, we're putting lidocaine down deeper. We have the numbing on the outside, and then we're going deeper with a needle and slowly injecting lidocaine because we don't want them to feel the pain. And again, pain, children, It's not just medicines. Remember, kids love to be distracted, whether it's coloring, whether it's stickers, whether it's a TV program, iPad, whatever, and just positioning. And sometimes it's heat or cold. So, and sometimes it's putting a little bit of acetaminophen in between a narcotic. Make sure we use all our resources on those kids. Now, 2 types of lymphoma. So we talked about, that one. Let's talk about lymphoma. Now, lymphoma, there's Hodgkin's, and then there's non-Hodgkin's. The ages, they're almost about the same. Non-Hodgkin's is slightly younger. Now, Hodgkin's is the lymph system, okay? Now, it is from the neck up, okay? Neck up, you're going to see big distended. You see those big lumps? They don't hurt. They're non-painful nodules. They're there. They don't hurt, but they start to get bigger and press on the trachea, which causes coughing. So that causes discomfort. Then they don't eat, and then they start with fever, weight loss, et cetera, et cetera. They bring them into the doctor, which they admit them, and they're going to be doing a biopsy of that lymph node. So Hodgkin's are big lymph nodes, non-painful, and neck up, all right? Shoulders up. This is where you see it. Now, when they do the biopsy, you're going to see Sternberg Reed cells. That is a positive diagnosis of Hodgkin's disease. We do radiation, we do chemo, and these kids do really great, really great. One of the things you need to know about Hodgkin's, especially if these are young girls, we need to tell the parents that there is a high risk of infertility on these children because of the radiation and the chemo, but they are going to live from Hodgkin's lymphoma. Now, non-Hodgkin's is diffuse. You don't see this. It's everywhere. You're not going to see big neck things. They're not going to be non-painful things. They're going to be all over the place. Okay? So Hodgkin's, big, thick lymph nodes, you see them, and they're from shoulders up. They're everywhere. Now, again, we're going to go try to find one of them, take a biopsy through x-ray, whatever, and we're going to be doing aggressive radiation, chemo, and go through all the stages of the chemo. And, it's harder to cure than the other one. Most common solid tumor in children are brain tumors. And what do we see with brain tumors in children? Well, if you have something occupying space that keeps growing, you're going to have a headache. And that headache is going to get progressively worse and worse and worser, right? Also, pressure in the head, because that growing, you're going to become nauseous. And you're going to be nauseous. It's not going to be related to anything you eat. And it's going to get worse and worse and worse. So headaches and nausea, vomiting. We'll find it, do the x-rays, CAT scans, MRIs, whatever, figure out what's going on finally. And we'll do radiation, chemo, shrink it, do surgery. And we're going to have to now know how to treat this kid post-operatively. Remember, these kids have a hole left in their brain for where that tumor was taken out. Make sure we listen to the doctor's orders and to the doctor. What side do we position them on? Do they go surgical side down, surgical side up? Head of the bed up, keep it flat. Some of them have brain drain, some of them ICP monitoring. So they could be seen in many different ways, okay? Another thing is when we talk about head and anything to do with head, like a head injury, we need to make sure we really are careful with intake, because you can go into fluid overload and it will increase the pressure of the head. And we do not want to do that, especially after we did surgical removal of a brain tumor, okay? And these parents need to be told what they're going to expect. Things hanging out of their head, a big incision, they can't move their head up, they need to be, informed so that when they see their kid post-operatively, they're not going to be as, going crazy, because I would if I was a parent and didn't know. Now, neuroblastoma, and you think neuro, something with the head, but neuroblastoma starts with a tumor in the abdomen that gets bigger and then it crosses the midline. So it starts on the side and then it takes up the space. I mean, that little baby you could see, that's a big thing that's gone on there and gotten bigger. Now, by the time we usually figure out what's going on, that tumor's already metastasized to the brain. Outcomes for these kids isn't good. Thank God it's not a common at all type of cancer. I mean, once it goes to the head, you're going to see neurological stuff going on because brain tumor with the compression where it is. You're going to see maybe the eyeballs coming out or edema or ecchymotic areas. So again, it's radiation, it's chemo, it's surgery to try to take care of it. But outcomes are not always good with these ones. And then at the bottom, we're going to talk about an osteosarcoma, which is a type of a bone tumor. Now, osteo is bone. Osteosarcoma, sarcoma is a type of cancer. This is a child. I've even seen football stars. I was watching a football movie about a kid in college who at the end of the career, he was like the #1 Heisman Trophy, like super duper guy, had pain in his knee that kept getting worse and worse and worse. And they finally, through that history, the limping, always the pain, getting worse, and of course the anemia, weight loss, infections all go with it. They did the x-ray, CAT scan, MRI, did a biopsy and found out it's an osteosarcoma. Now, what do we do for an osteosarcoma? Most of these are on the femur, and most of these are your young adolescents. Some of them are older, but mostly in that adolescent area. They have to take out the whole femur bone. Doesn't the femur bone go into the socket of the hip? They got to take the whole bone. So what they're doing today is they're taking the lower leg and attaching it backwards into the hip socket, and they're doing it successfully. And why would they do that? Well, now you have somewhere to put a prosthesis so they can be mobile, which is what they want to do. So osteosarcoma, you have to remove that whole femur bone. Our goal is to salvage the limb. If we can't, sometimes they do have to amputate, and then it's going to be harder to find a prosthesis for them. Another tumor is a kidney tumor. It is African-American, boys, ages 3 to 5, and I've seen one in my career. It was a kid that came up after the Haiti earthquake through a religious group, through the airport. They picked him up, brought him over to the ER, and I was in the triage area. And I said, why is he here? And they go, we don't know. We were just told to bring him here when we picked him up. I'm like, okay. All the records were in French, so I couldn't even read that. So I did a good assessment. So I did, a neuro check and vital signs and listened to the lungs. I was listening to the abdomen. And when I felt that left lower quadrant, I felt like a baseball-sized tumor there. And for some reason, I knew it was a Wilms tumor. Now, the big thing with Wilms tumor is it's fragile. And if you touch it, pieces will fall off and metastasize inside the peritoneal cavity and attach somewhere else. So do not palpate the abdomen. Huge thing with these kids. So what they do is they do no biopsy, because if they do a biopsy, they're spreading the cancer inside the abdomen. So they just do the x-rays, they figure it out. Sometimes they'll do chemo or radiation before, sometimes not. And then they'll go in and do surgery. Now, they go through the front, but the kidney's way in the back. So they've got to go through all the bowels. So a lot of times you have paralytic ileus after surgery. You got to watch their bowels. And you're taking a tumor off a kidney. So now you're watching urine output post-operatively. This little boy did well, went back to Haiti, and actually through some foundation sent a card back to the floor where he stayed, and told them thank you. He was doing well. So it was a good outcome. And to this day, I don't even know why I knew that was Wilms. Rhabdomyosarcoma is little soft tissue sarcoma, ears, nose, eyes, and it's just you start seeing things getting bigger or something not looking right, and they need to go in and they need to resect the whole tumor out of there. Retinoblastoma is a cancer of the retina. And what you see is what we call this cat's eye or this whitish glow. Ever go in your backyard, the porch light on, and you see a cat, a dog, a deer, a bear or something, you see these sparkly white eyes in the background? Well, you're going to see that like up front and close with these kids. It looks just like that. So they're going, these kids need to do irradiation. And those little purple things that they put there, we never wash them off until they're completely done. So that's where they have to zap the radiation in there to try to shrink the cancer. And what they do is they do surgery, remove the eye. And when they remove the eye, later on, they are fit with a prosthesis. So they will have something to put in there later on. But again, this family needs great. You have the one I saw was just one, was an 8-month-old kid. And this kid, had the eye taken out, and it was support of the parents, I think, was the hardest. The poor mother was crying. She's going to lose an eye. I said, she's going to be okay. She's going to be okay. But who am I? Germ cell tumors. All right. This is another story I got for you. This is basically testicular cancers. Kids that come into the ER with testicular pain are a high emergency for many different reasons. But this was an 18-year-old boy, just turned 18, came in complaining testicular pain. When we did an assessment and looked at the testicles, they were big and large and hard. And I just said, oh my God, no. It was already metastasized. So we did an X-ray of the chest and the abdomen and the ultrasound of the testicles. He already metastasized everywhere. The kid only lived for 3 more months. It was horrible to watch. So women, you check your breast every month. Men, check your testicles every month. And that's the story with that one. Livers. Don't we have multi-lobe livers? You take out a lobe, you got more left. So that's not too bad with livers. They actually do very well. So survival rate is better. I think it's even better than 80% today, because I know even with the cardiac children, there are lower numbers. Yeah, a lot of them are surviving. Therapies have changed, the way that we do things, the way we combine things, it's just so much better. So, in Facebook, I used to always see these pictures of adults and children and these pictures of cancer-free, and it just always used to make me smile because, that is our goal. Kids, they don't deserve it, but we've got to give them their best outcomes we possibly can, don't we? Any questions? All right, you ready for a cahoots? Who wants to win a cahoots today? All right, everybody's hands up all at once. I want to win. No, look at you. Okay, thank you, Elise. I appreciate you. Was that you too, Ghana? You were trying to do it too? Okay. So if you can join me tomorrow at 2 p.m., I'll be giving a review. If not, probably by 4:30, you're going to have it posted in your announcements under exam 2 reviews. Okay. And let's go. Week 6. Which statement best describes a neuroblastoma? Remember, the name sounds like it's all head, but remember, it starts with the belly, right? And it gets bigger and it spreads across the midline. So diagnosis is made after metastasis, and usually outcomes aren't great because of that, or it's a long treatment. What is priority treatment for a newborn of an HIV positive mother? What did I tell you what we need to do for that newborn? I mean, does a newborn born of an HIV positive mom, are they destined just to have HIV? And we just want to improve their immune system, and many of them what we call zero convert. And it's just a wonderful happening that I've watched. What are symptoms of sickle cell anemia? What's the kid going to come in complaining of? It's a little bit of everything, isn't it there? But when I see the swelling, that's probably the more sickle cell, because if you have a sickle cell in your elbow, you're going to see the hand or the knee, you're going to see the feet swelling, and all of the rest are with that also. All of those things, you might be seeing them. Hearing issues, maybe not. Sickle cell anemia affects which cells? It's all the red blood cells, okay? I just wanted to make sure you know it's the red blood cells that carry oxygen and nutrients to the cells. What kind of hematocrit would someone with sickle cell have, and why? So remember, sickle cell cells die really quick, okay? That's why it's going to be lower, all right? It has to do not with production, that's aplastic anemia. These cells, like thalassemia, die quickly. What is the treatment for sickle cell anemia? And we know sickle cell has to do with inside the vessels, and we know it's probably due to dehydration. So number one is IV fluids. Bolus it, let's give some warmth, let's dilate that vessel, let's get the blood flowing, and on the other hand, have that pain medicine. What is the reason children with iron deficient anemia are tired easily? Not chickens, children. My grandson, if he was here, would be chuckling right now. Chicken, Nana? What do you mean, chicken? Iron deficient anemia, you don't have red blood cells. You don't have red blood cells, you don't have oxygen. Your cells don't have oxygen, they're going to be tired, and the kids are going to have no energy. I've been babysitting my grandson for the last week, and I got another week and a half. My daughter is all over Europe and Dubai and Turkey, and I don't know where. Aplastic anemia includes a depression of which cells? Remember, aplastic anemia. I mentioned it earlier in this cahoots. We know it has to do with red blood cells. That I'll tell you. Because anemia is always red blood cells. So whenever you're picking, you're going to pick that one. But it's also the white cells and the platelets. There's one, that's only the red blood cells. But really, when we think of it and questions are about it on exams, I always see it geared towards all of the cells. We treat it like leukemia. Let's wipe it out. Let's give a bone marrow transplant, and hopefully we'll reset it. Most common type of anemia is iron deficient anemia. Thank God it's not aplastic anemia. Iron deficient anemia, how do we treat it? Well, we increase the iron in the diet or we give some sort of iron. I mean, one of the most drastic we can give is iron dextran. Remember, that's a Z-track IM that we give. In fact, that was my first injection I gave as a nursing student, a Z-track. What causes pernicious anemia? Pernicious anemia, that's the intrinsic factor, right? And that's the B12 deficiency. Again, once we replace the B12 and we get those cells being re-established, so the anemia goes away. Which symptom is the single most common symptom of anemia? This is what always brings these children in. And this is, I mean, all the symptoms are here in that beautiful picture, but it's always, my kid's tired, he's not moving, there's something wrong. If you have a kid who's running around constantly and they're sitting there doing nothing, yeah, something is wrong. They're sick or something. When teaching parents about beta thalassemia, the nurse informs that child is at risk for what? So beta thalassemia, Cooley's anemia is just like sickle cell anemia. Remember, they are chronically just bursting those cells really quick. They're rectangular. What's inside those cells? Oxygen and iron spewed out. Don't have oxygen, so chronic hypoxia and iron overload. How do we treat it? Blood transfusions, insulation therapy. Let's get rid of that iron so we don't go toxic. What lab values will you see with hemophilia? So in hemophilia, we're going to see a prolonged bleeding coagulopathy, the APTT, prolonged, like they were on heparin, and nothing else is going to be abnormal. And once you see that, you're going to be pulling those bloods for those factors. Priority treatment for a child with sickle cell crisis is the first thing you do. We got to treat the reason while they're in a crisis. Don't treat the symptom, which is the pain. IV fluids, number 1. Heat, 2, 3, pain medicine. Okay, that's the way I would give it. And usually all at the same time. What is immune thrombocytopenia purpura? ITP. What did I tell you about the P in thrombocytopenia? Remember, it's usually caused by an upper respiratory infection. It can be acute or it can be chronic. And it's a decrease in the number of platelets. Remember, ITP has nothing to do with blood vessels. It only has to do with there's bleeding and you see either ecchymosis or this purpura type of rash, okay? How do we treat it? Intravenous immunoglobulins, anti-vitamin D, and maybe corticosteroids, and always put them on bleeding precautions because they bleed very easily. Thrombocytopenia can cause the following symptoms. And usually this is how we diagnose these children. These kids come in and they got these rashes and they don't know how they got them. or these bruising and their nose are bleeding and the kid didn't bop his nose or anything, that's when we'll go start looking and we'll see that low platelet count. Remember, any child that has a low platelet count is your big concern, will always be bleeding. And they can have it because of sepsis. That's one of the big things. They eat platelets. Multi-select. Child with hemophilia has fallen, the knee is swollen and painful. Treatment would include remember the acronym PRICE, right? Protect, rest, ice, contain, elevate. So we're not going to exercise and we don't want more bleeding to go in there. We don't want hot packs, that's going to cause more bleeding. We're going to elevate it, ice packs, and we're going to rest, and we're going to probably wrap an ace bandage around it. What is the priority nursing action for suspected blood transfusion reaction? So you're giving blood, you're hanging it up. 15 minutes later, this kid all of a sudden spiking a temperature of 102, and it was normal when you took him 15 minutes ago. Number one, stop the infusion. And they always come in a bag, and you just take that and the tubing and everything, put it in the bag and get it down to the blood bank. Very good. Of course, call the doctor. A child is admitted with neutropenia. Which nursing action takes priority? Kelly, you know this one. Again, that's one of those terms that you need to know what neutropenia means. Remember, that's just a decrease in white blood cells. You don't have white blood cells, you're out to get an infection. How do we as nurses prevent it? What's our priority? Washing hands, especially in between patients. I mean, sometimes we have to run into rooms because stuff are happening. But today there's an alcohol thing that you push on the way in there. It's just so easy to keep our hands clean for patients. What symptoms would a healthcare professional expect to see with a child with leukemia? This is just what my next door neighbor showed up with. And bruising, fatigue, bone pain, absolutely. Sometimes fevers with that, and then they'll go and they'll check and find what's happening. Your child with ALL has recent lab results with a platelet count of 10,000. What is your nursing action? Remember, it doesn't matter if your kid is ALL or it's just a kid with something else going on. You see platelet counts of 10,000 for any patient. What is your priority action? I mean, what does platelet counts of 10,000 mean? It means you can bleed. So you put these patients, big kids, adults, or children, bleeding precautions because they will bleed easily. A multi. Child's placed on bleeding precautions for ITP. What interventions would the nurse do? Immune thrombocytopenia purpura. So we're going to do all of these. We're going to no injections, look for active bleeding, monitor. I want to see if their platelets are low, what's going on. Because remember, it's all about P, platelets. And then corticosteroids might be one of them. What's the normal treatment? IVIG and anti-vitamin D. And it could be a chronic condition that if we're treating after a year, then we say it's chronic and they're going to have to continue the treatment for it. Keep those platelet counts up. Child with Wilms tumor, what action by a nursing student causes a faculty member to intervene? What's not right? You had to intervene, something wrong. And remember, Wilms tumors are very fragile, and it could put little specks of, cancer in the peritoneal cavity and cause metastasis. That's why they don't even do a biopsy. They don't want to stick a pin in there to make it, put the tumor, any cells anywhere else. Cancer of the body's blood-forming tissues, including the bone marrow, is called what? You're talking about blood forming, it's leukemia. A child with ALL has a fever of 100.5. What should they do? They're at home. What are they supposed to do? What have you taught them? And when you think about it realistically, ALL, they don't have any white cells. They got a fever, they're in trouble. They need to get medical attention right now because the doctor is going to order some sort of antibiotic or for them to get into the hospital, get something IV. Child's having a bone marrow aspiration. What should you tell the child? Yes, it's going to hurt. Excuse me. But we'll do everything to make it as little as possible. Most common clinical manifestation of a retinoblastoma. So this is what we call a cat's eye reflex. That's when the retina gets really white and you could see it. It's almost like that old, you took a picture with a flash bulb and you see the white eyes, same sort of look. And remember, the treatment is radiation, chemo, and removal of the eye. Your child's been diagnosed with retinoblastoma. What information is important? So we can see that there's something wrong. We can see that there's that white eyeball. What is some more assessment information that's really going to help make the diagnosis? So we want to know, has there been any history of going on with that eye? Any signs, symptoms, redness, swelling, anything. And that's going to help us with that treatment. A goal of surgery for a child with an osteosarcoma is what? Remember, osteosarcomas are usually long bones. The most common you see it is of the femur. We want to try to save that leg part of it. So we save the lower leg and put it up into the hip joint so we have somewhere to put a prosthesis. That's the reason. Immunizations cause autism, yes or no? No, absolutely false. In fact, the physician who did that, quote, research study lost his license because of it, because it was a false study. A child's complaining about skin markings for radiation therapy should be told what? Remember I showed you that little purple thing above an eye for that retinoblastoma? What do we do with those things? So we know radiation needs to know a space to go. And we want to keep the same mark so we're getting the same place to zap every single time. A multi-select. Nursing care of a patient with immune thrombocytopenia purpura, ITP. What's the treatment? Excuse me. Remember, it's all sorts of bleeding precautions. Again, I said it twice. I'm going to say now the third time. ITP has nothing to do with blood vessels. They don't need to be dilated. This is all bleeding as in bruising and rash, sort of petechial rash. Has nothing to do with blood vessels. You don't have to give IV fluids. You treat this by bleeding precautions, no IM injections, monitor CBCs, and giving corticosteroids PRN. Also, we're going to give the IVIG and the antivitamin D as ordered. When distraction is used, it helps what? So when you use distraction, it helps with everything. It decreases the pain perception. It helps them not think about themselves. It is a great tool with children. I mean, when I worked in newborn ICU and I worked night shift for many, many, many years, I'd have music on at night. And I'd have, of course, my channel on, the Golden Oldies. But these kids would sleep all night long because the music was a distraction to all of those monitor noises. What assessment question needs to be asked to a child with possible rheumatic fever? Again, this is a question from last week, and you know I'm going to hit you with some of them. What is rheumatic fever caused by? And it's all about that strep throat, okay? It was an undertreated strep throat. How do we treat it? We're going to treat it with antibiotics, amoxicillin, a penicillin type antibiotic, and probably 4 to 6 weeks at least. Signs and symptoms of asthma, another last week question. So there could be coughing, shortness of breath, and again, it's that expiratory, prolonged expiratory phase. They get air in really easy, and then it gets trapped. So it's really hard to get out, and they will wheeze as they try to get it out. Very good. Another multi. What symptom should be the healthcare provider for a child with sickle cell disease? So a headache and chest pain are priority. The other ones we're expecting. Sores that don't heal, that's not sickle cell. Swelling of hands or feet is something that does happen. But when all of a sudden you have symptoms of severe headache, maybe it's a stroke. Chest pain, well, maybe it's a coronary artery, or maybe it's a pulmonary embolus type looking thing. So these are the symptoms that we report. Absolute contraindication for nasal-tracheal suctioning include which of the following? When don't you put something in a child's mouth? So anything that has to do that can increase swelling, which causes a problem. Croup, which could become epiglottitis, or after a tonsillectomy. You don't want to disrupt those scabs and cause bleeding, because I've seen hemorrhage from post-tonsillectomies. Iron dextran is given via which route? It was my first injection as a student nurse. And the lady was like 40 something. And I'm like, couldn't it at least be an old person? but she told me I did a good job. So thank goodness. It's IMZ track. It burns and it stains the skin. So you put it in, took it out, and you lock and load, as I call it. If a child was to receive their own bone marrow, this is called a blank transfusion. When it's mine, and that's called automatically mine, autologous, right? Allogenic is all everybody else. What cancer may present with painless, firm, and enlarged cervical nodes? That means above the shoulders. And that's Hodgkin's lymphoma. Excellent, good job. A multi. When teaching about sickle cell disease, you would include what? So you'll never say to limit fluids. We want those vessels to be big. Very good. You want to dress warm, keep those vessels again big, take medicines before, and of course, any temperature, get a hold of your doctor. Good. Thalassemia major is treated primarily with what? Thalassemia, Cooley's anemia. And it's blood transfusions, because their vessel, their blood has these little rectangular little cells that are made. They make them good, but then they burst. And what happens is the iron and oxygen are spewed right into all of the bloodstream. So the hemoglobin hematocrit are constantly low, low, low. So it's blood transfusions and some sort of iron chelation therapy. A multi-select. What are opportunistic infections of HIV? You know, I learned all about one of these in the early 80s when HIV just came about. I was doing an agency shift in an ER, and I had an HIV or an AIDS positive patient go in respiratory distress, and they go, oh, that's PCP, that's normal. And of course, I had no clue what they were talking about, so I had to go look it up. But also candida that you see, whether it's vaginal or young babies, you know, on their tongues. Another multi. Treatment of an osteosarcoma includes so an osteosarcoma is the femur bone, a long bone. Let's say it's the femur bone. Sometimes it's the humerus, but usually the femur. We need to take it out, or we try to salvage it, and we do give chemo. There are no cells that you have to replace here. It's a bone. So stem cell has nothing to do with osteosarcoma. Another multi. Who are the best donors for a bone marrow transplantation? You know, you can get it from anywhere, but yourself is always number one, and siblings are the second choice. If you don't have that, then you would go to another person, but those two are your best choices. What is the most common opportunistic infection for children with HIV? And that's your PCP pneumonia. I mean, you can have, the Candida, but PCP is the most common. What would you consider to be neutropenia or a low neutrophil count in children? And remember, that patient's going to be your priority. And that's less than 500. Usually it's like 1,200 to 2,400. That's about normal, or 1,000 to 2,000, depending on what lab value you're looking at, which lab. 500, very low. A primary characteristic of a brain tumor is so you're going to have headaches and you're going to have vomiting, but it's going to get worse and worse and worse as it goes. So remember, headaches, sometimes it'll even wake them up from sleep. That's how bad they are. And vomiting has nothing to do with when you're eating at all. And it gets worse. The optimum treatment for an osteosarcoma is, what is your goal? What would you prefer? The best for the child. And that's salvaging the limb. You might have to do an amputation, but your goal is the salvaging the limb. You cannot keep any piece of that femur in there, or the humerus, whatever long bone it is, because the cancer will spread. The whole bone must come out. And last question. A child is receiving the induction of chemotherapy. What does that mean? Remember, that's the first stage. And it's the initial intensive chemo with the goal of remission. And hopefully we got most of the cells, and then they're going to go back and find the rest of them. Get them. They'll be hiding. Mayona, number 3. Good job. Number 2, Bobby Bouchard. Good job, Bobby. Number 1, Cam. 4. Smiley faces and Kristen. Good job, guys. All right, what I want you to do is go to your modules. Go to your quiz. When you are done with the quiz, you may leave. Does anybody have any questions for me? All right, I've covered everything on the quiz. Go for it. Everybody get your 10s. It's an easier quiz than the last 2 weeks, okay? I think. And the students think it so far. I'll be quiet now.